All right, hi. Might as well get a little head start here. Thank you for coming. I'm Raymond Kwong. I'm a professor of medicine at Mass General Brigham. I'm also the director of Cardiac MRI there for over 20 years. It's really my privilege and honor to be here to speak to you about our experience over the last few years, focusing on the results of the last 2 years using AI assisted CMR scanning. Now, I want to emphasize that this is not only post-processing, but this is the novelty of this is the AI guidance performs a scan along with our technologies. And I think I want to show you the results. First off, let's see here. This is going to go back here. Well, I have no disclosure, but I'm not being supported to speak to you today. So I'm focusing on the science that I hope will interest you. Okay. So let me just share with you our challenge to start with. Our challenge in the Boston area is that we have to cover 6 different regions, 6 different patient groups, and amongst them 3 hospitals that ship their patients to be needed, inpatients or outpatients to be scanned, so many of them urgently at our Longwood, or you can say the medical school region where we perform cardiac MRI. We serve a catchment area of about 2.5 million patient population in the greater Boston area. And sometimes to deliver care for this urgent, often sick inpatients can be challenging. And because of zoning and other factors, buying new scanners and having more technologists, recruiting more technologists, those are not always a solution. They're certainly not short-term solution. So how do we solve that? On the other hand, we also want our cardiac MRI protocol to be comprehensive, to be detailed, because we want to be able to answer not only basic anatomy, but we want to be able to deliver key messages on myocardial physiology, structures, tissue characterization, valvular dysfunction and physiology. There's a whole host of information that we can learn from a cardiac MRI. How do you balance that? How do you balance the many pulse sequences, which they have to be played out in specific orders, and we have to attend to the patient's need as well as the challenges of patients when they're unstable. And so we want our exam to be comprehensive to answer all these questions, and often the average scan will take as long as 60 minutes or close to an hour, sometimes even longer. So obviously that will cause a logistic and practical challenge to the limited scanner resources. During the pandemic, we experienced a tremendous amount of growth. Just basically the city is getting, there are patients that need to be scanned. We're shifting more into a non-invasive way of practicing cardiology. So to meet that demand, we need better solution. And as I mentioned, buying new scanners, hiring more technologists is not always possible, and at least not in the short term. But yet you can see that we implemented AI about 2 years ago now. We tested it for about a year. So since 2002, there's a progressive jump of scanning volume. Now, these numbers are after years of cleaning out our protocol. So our protocol is already tailored to the patient-specific needs. And even after that, we still have a backlog, a substantial backlog in up to about 2002. It's still a very stressful situation. How do we deal with that? I'm going to share with you some of the methods that the AI guidance will actually deliver. The AI by Vista, what it does is it does 4 things routinely in each scan. The first thing is to locate and plan the scan planes of the different sequences. You can pre-arrange these and pre-scan them, and it will automatically detect the AI automatically detect the anomaly in about 30 seconds. Without the AI detection, typically even for our experience, technology would take about 5 minutes. So that is a cost saving and also is much more consistent. The second thing is amongst many sequences, it will perform automated parameter tuning. Now, what you're looking at here is really just a way to look at the TI scout, to look at the TI knolling to perform late enhancement. You can see that run through a course of different TIs and pick the one that is most optimized and already apply for it. You don't have to type it in. You just basically have to keep on. The scanner will continue to scan. If you don't like it, you can actually change it and rerun it or make some adjustments to it. So the third thing it will do is it will actually perform some limited analysis. Now, we are using this on the fly. So before the patient gets off the scanner, a lot of the parameters are already quantified. LV, RV functions, sizes, strain, those are already quantified for you to look at before the patient gets off the table. And another addition is the add of real-time motion and artifact detection. It will automatically switch, if the patient has arrhythmia, it will switch to a real-time scan by itself without you interfering. So this is really helpful for unstable or patients with arrhythmia. Another tool that I really find it very helpful is to assess for cardiac heart valves, the automated vein scout and plane location. What it does is it will automatically locate the aortic valve and mitral valve in one click. And then it will calculate the velocity encoding for you, so you can optimize the flow calculation, the flow and velocity in basically one or two clicks. And you can get the valve done very efficiently. Valves assessment has remained to be a challenging indication for many years. Let's look at the scan numbers. This is a breakdown of the first 6,600 patients. I'm showing you this is the cohort I will use to present to you. You can see that the numbers the breakdown is like that. And the scan time across these 7 indications are reduced by, as demonstrated. The reduction of scan time, again, the blue bars are the automated AI-guided scans are shown here. The biggest reduction is in the more comprehensive tests, such as stress cardiomyopathy and the valves, because the AI automatically perform a better job. But across all indications, there is substantial statistically significant reduction ranging between 17% to up to 35%. On average, we have a reduction of overall scanners average to be about 26% reduction of scan time, but that's not the real benefit. The real benefit is I know that operation on a daily basis, the variability of the scan time, as you can see in the standard deviation of the scan time here, is about half. So I know the consistency of the operation is twice as consistent, which for an operation standpoint is important. Scan quality is shown here on a scale of 0 to 5, 4 and 5 being high quality scans as listed here on the top here, the scan quality score. In the red are the scan quality scores without AI guidance. In the green are the scan quality scores with AI guidance with Vista. You can see that there is an improvement consistently in the key sequences, RSNA and perfusion and so forth that substantially improve. They're statistically significant. A few things about the outcome of the patients. These are patients that we have shifted to primarily AI as a default program. The outcome is pretty much consistently similar, favorable. The outcomes are not that different, which is not surprising. What is actually a little bit surprising is that since the implementation of AI, probably because of the expansion of access to clinical referral cardiologist or primary care physician, the cath rate from the patients with cardiomyopathy, the need for downstream cath is slightly reduced. There's a trend in reduction of the need for cath. Overall, subsequent testing on referral to other modalities are also somewhat lower as well, although we need more long-term data to study this. What is interesting, though, is if you define a success of a scan as diagnostically good quality and the patient get out of the scanner in 45 minutes, if you define that based on those two criteria, as seen in green there, that is the proportion of success we have seen over the last 2 years. Before the AI guidance was implemented, we were only getting that success in about 50%. But since the AI guidance, after training, progressively, we're getting that level, getting the patient out the door in 45 minutes and diagnostic in over 95% of our whole patient population. As you know, we're doing AI guidance as a default. So over 90% of our scans are AI guided. So there is no cherry picking in showing this graph. What does that mean to our patient workload backlog? These are the per quarter scan numbers seen here. There's a progressive growth over a 1 year period for inpatients and outpatients. But most importantly, because of the AI guidance with the same single scanner, single 3T Prisma scanner, we did not buy more scanners, we did not hire more people to run more shifts. We did open up a Sunday. We were able to reduce the backlog of wait time from 5 weeks to about 3 days, 1 to 3 days. And we have been able to keep that down to about 1 to 3 days since last summer, since the summer of 2023. That's still the trend here. So there's been a tremendous improvement and almost revolutionary change to the operation of our cardiac MRI program. With that, I will summarize that AI by Vista AI is an FDA-approved AI-assist CMR imaging method. Our experience at the Brigham over the last 26 months of implementation resulted in an average scan time reduction by, on average, of 26%, although some could reduce by almost 37%. It resulted in 3,000 scans performed out of a single scanner, of a single 3T system. The wait time went from an average of 28 workdays, 28 hospital workdays, or that equates to about 5 weeks, to 1 to 3 business days. That represents a 50% increase in the available slots in the same image, using the same imaging equipment and staffs. And that represents that there's a more than 2 times improvement of scan time consistency. What that means is the day in and day out operation from 7 a.m. in the morning to 7 p.m. at night is much more consistent. And our technologists also report, our physician readers reported that the image quality has substantially improved. And our technologists also reported that despite of the increase in volume, the work stress to handle the sickest of patients, again, 20% of our patients are inpatients, the work stress is actually lower. So I think those are all very positive changes. Thank you very much for your attention.